Hello and welcome to my channel. My name is Peter Abraham, a registered nurse primarily in the field of hospice. If you're new to this channel, welcome. Thank you for visiting. In this channel, we discuss chronic illness that becomes terminal illnesses, topics for hospice nurses, topics for caregivers, including anticipatory and grief. For the last several weeks, we've been dealing with topics for hospice nurses. Today is going to be no different. Before I go much further, every episode I do like to go over areas of gratitude, and I encourage all my subscribers, everybody visiting, please take a moment out of your day and ask yourself, what are you grateful for? In my experience as a hospice nurse, I gain resilience. That's that ability to snap back from bad events, sad events, tragic events by having a heart of gratitude. And you don't get that in one day. You get that over time by starting a habit, a daily habit of what am I grateful for? It could be as simple as I woke up this morning. I was able to have a cup of coffee or a bite to eat. What are you grateful for? So in terms of what I'm grateful for, I'm our raised beds. We survived 2 frost nights. Um I ended up digging holes for 2 vegetable trees. Vegetable trees. Oh my word, I'm losing my mind. 2 fruit trees that I'm not normal. 2 fruit trees that we're going to be planting hopefully before the end of this week. A Honeycrisp apple tree, and I might be pronouncing it's either Arkansas or Arkansas, but a black apple tree, and I've never had black apple, so this will be an interesting adventure for that. So that's going on. That's going well, and I'm grateful for those who are purchasing the different books that I have written. Thank you, Amber. Thank you, everyone who's been buying the books. And I'm thankful for making progress on the clinical pharmacology book. That chapter 3 is done. Fine tuning chapter 4. We'll be doing reviewing chapter 3 shortly. Next episode of that will be chapter 4. Chapter 3 is on the liver failure. The next chapter over that is cardiopulmonary. I'm very excited next week to show you that chapter, because I don't know about you as a hospice nurse or a fellow nurse if you're not yet in hospice, but one of the hardest cases that I've ever had was when the diuretics are failing and you don't know what's going to happen first. Like, I'm praying that the patient's going to die before that they get too full of fluids. So, and I don't always use the right words, so I'm sorry for that in advance. But let me walk you through looking at the clinical pharmacology aspects of liver failure. After that walkthrough, we'll go on the outro. So I'll see you on the other side of that. Continuing with hospice clinical pharmacology for the next chapter, which is dealing with liver dysfunction, the hepatic system, looking at medication safety. So like the previous chapters, the learning objectives, metabolic principles. Liver is the primary organ for processing our medications. There's a two-pass system as well as the biliary excretion. So as our hospice patients are declining, even when they don't have liver disease, there will come a point for multi-organ failure, for liver impact. And if you have anyone with liver cancer, cirrhosis of the liver, these become even more important. And we're also looking at the hepatic blood flow, protein synthesis. What I try to do in all of my books, and I mentioned this in other episodes, my foundations as a hospice nurse, as a rural hospice nurse, where we did not have easy access to labs, and in many cases, there wasn't a need for labs. So I try to present the data as to how would you know based on what you're seeing, what are you observing with your senses, where possible, your stethoscope, your blood pressure cuff, etc. But what are you seeing? So if you're seeing jaundice, we can expect that their bilirubin is going to be greater than 3. So what does that mean medication wise? For anything that's clear through the liver, maybe we need to consider dose reduction. If they're having liver flap, hepatic encephalopathy, got to watch our CNS depressants, consider dose reduction. Spider angiomas, chronic liver dysfunction, long-standing liver impairment. Palmar erythema, that's with your hands where it could be either red just in the palms or look like petechiae all over your palms. Altered estrogen metabolism, chronic liver dysfunction. And factor, I'm going to kill the pronunciation of that word. That's that odor from the breath. That's advanced renal impairment. I'm sorry, kidney impairment. And they typically don't last too long after that. So in terms of medication adjustments to consider, your morphine, your oxycodone, your certain benzodiazepines to watch for, your NSAIDs, acetaminophen if it was higher doses, and that's where you may want to consider 2 grams versus 3. And statins, which for me as a hospice nurse, my philosophy, hopefully it's yours too, the absolute risk reduction for statins, absolute risk reduction for any medication, is the percentage of benefit for their intended purpose. So for statins, the intended purpose is to lower your bad cholesterol to reduce the risk of strokes, heart attack, and other forms of mortality. Well, what is that risk reduction? A massive, in a healthy person, a massive, whopping 0.8%. And I'm not kidding you. It is one of the worst drug profiles to say there's any benefit to it, less than 1%, for side effects of increased cognitive impairment that can lead to dementia or worsening dementia. Increased blood sugars that could lead to prediabetes, diabetes, brittle diabetes, worsening muscle aches and pains that could lead to the point where you can't walk anymore, all for a massive 0.8% benefit for the healthy people. It's even worse in our terminal. Look for safer alternatives, general dosing guidelines. And as in previous chapters, when we go over, there are going to be case studies, but there's also clinical examples to consider. When we're dealing with liver is the primary area for albumin that helps our body have fluids in the right locations. So if albumin goes down too low, that's where we have ascites, that's where we have fluid in areas that we normally don't want to see. There's also drug changes for hypoalbuminemia as well. Drug buildup, unpredictable reactions. Now, there are certain medications that are highly protein bound that we need to be careful for. Warfarin, Coumadin, increased anticoagulant effect, even if they're taking the appropriate dose, they're at risk for excessive bleeding. phenytonin, valproic acid for your um, anti-seizure medications, diazepam, NSAIDs, and furosemide. So there are going to be times where what's going to be the approach if there's a clinical finding? Well, if there's minimal or no edema, most likely the albumin level is normal. But getting back to rural hospice, we don't have access to lab all the times. If you're seeing mild peripheral edema, they're probably having mild hypoalbuminemia. If it's moderate, again, more. Anasarca, significant ascites, they're probably going to have significantly low albumin levels. What should be the medication management? And I've shared in other overviews, at the end of the day, the doctor is going to be in charge, but we as nurses need to be that front line communicating with the doctor. And if we're receiving information back, like we can't walk into a situation, oh, the doctor ordered XYZ, and they may not be up to date with the latest assessments of what we're seeing. Then there's these phase 1, phase 2 interactions and considerations for that as well. We do need to consider benzodiazepines in liver disease, where the half-life is extended. So diazepam in liver disease could be over 100 hours for a single dose. Lorazepam, it's minimally effective. And most of our comfort kits, I cannot speak for your hospice agency, but I've worked for several hospice agencies when I was in Pennsylvania, and in our comfort kits, we predominantly use lorazepam. I've only worked with midazolam at one time in terms of a patient where we're concerned about loss of airway. I've worked with diazepam in terms of seizures. So why do we avoid diazepam in liver disease? Very unpredictable results. Lorazepam's better. Then in terms of opioid selection, morphine we have to be careful about. Your Dilaudid works better. Consideration with morphine, considerations with looking at fentanyl and the advantages. Again, with the clinical examples. And then how do we do risk evaluation, especially in the field where we don't have labs? No jaundice, normal mental status. What do we consider? What if there's mild jaundice and subtle mental changes? Obvious jaundice, confusion. Key practice points. Getting back to what if we don't have lab data? So jaundice, looking over the location, progression, the liver flap, how to grade it, clinical examples. Spider angiomas. sometimes referred to as the death breath. And then a table for quick, 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 comprehensive clinical assessment. Again, looking at practical applications out there in the field. Then in terms of case studies, there's 2 of them going to be dealing with pain. I switch from the fentanyl in this particular case. Why are we heading in this direction? Follow-up monitoring. Now, I know as hospice nurses, we're not there. We're there for a visit and we're moving on. So the follow-up monitoring, these are things to communicate either with facility staff, if this is a facility patient, the family, the primary caregiver. And depending on what you're doing, there should be a follow-up visit or at least a follow-up telephone call. Another one looking at pain. And in this case, looking at Dilaudid. Then we're switching over to a case study looking at benzodiazepine. Now, what are we going to recommend? Now, as an FYI, you might be having a case where it's not diazepam, but it's another benzodiazepine. This is again where you might look at, this might be better to look at lorazepam. And as you're going through, prognosis always matters with our hospice patients. So the closer someone is to death, you might end up taking the approach of we're maximizing comfort. If we make any switches, even if it's clinically sound from a textbook perspective, you're going to do the right thing. And you might say the right thing is we're going to just leave everything as is. You're the one in the field. My book is not out there. I'm not out there to judge you, and neither is what I'm writing out there to judge you. You're out there in the field. What I'm writing is to help you brainstorm, especially for those patients that come on and they're in the 3 to 6 month mark window, or maybe they're in the 2 to 4 month window and they have more time. Let's make them more comfortable and reduce the burden of the medications. Let's make sure they're on the proper medication regimen. Then looking at Tylenol. Now, as a side note, I've had medical directors that they literally, and I don't mean this in an apathetic way, and I don't mean this to judge the doctor, but they're in hospice. I don't care if it's 3 grams or 5. If it's helping them, it's helping them. And this gets back to, at the end of the day, the doctor has the final say. We are not doctors, but that doesn't mean that we could not have a educational discussion with our doctor where we could get educated as to their thought process. Or maybe in this particular situation, there are glimmers that we could share with them, and they may come back and say, and I've had this, Peter, I didn't know that. And sometimes it's a compromise. And sometimes they'll actually, okay, Peter, let's go down this route. And that's, for me, that's always a good feeling. And again, the S bars. Now, some of you who are watching this and may say, if you were to buy this book, well, you've been doing hospice or nursing in general for 10 or 20 years and you know SBAR like the back of your hand, please keep in mind that this is for nurses at any level. My goal is to just try to help everyone bloom and become an expert in their practice. Antidepressant accumulation. I've run into serotonin syndrome. It can be very hard to detect, but it is something that can cause immense distress and appear to be terminal restlessness when it's not. And by dealing with the situation, you may add a week or two, or maybe even a month or more of life to a patient. And it's not that we're there to try to purposely prolong life, but restlessness is not comfortable. So we should be treating it, and treating it is not always adding yet another medication. So this goes into what if we need to look at the antidepressant. So sertraline, you have to watch for rebound. Your provider may say, let's start weaning off, we'll reduce, but then depending on where things go, end up eventually coming off. As a side note, I believe it was June or July of 2022, a major scientific study came out that all of the previous studies showing that depression was caused by a chemical imbalance was paid for by big pharma to promote antidepressants, and it's not a chemical imbalance. I'm not saying antidepressants don't have their place, but it really shook up the psychology industry, the antidepressant industry, that it is not a chemical imbalance. So in my experience as a hospice nurse, depending on where, again, prognosis driven, I've had cases where we're not introducing antidepressants because they don't have that. They don't have 6 to 8 weeks for them to kick into effect, and we can't go through the titration cycle. That's its own long story. But then we have the conclusion, and with all the chapters, discussion questions, practice scenarios, and Socratic questions. Thank you for watching this. Look for the outro. Thank you so much for your time watching that with me. If you like what you're seeing, if you have comments, please comment down below. That comment could be anything from, can you tell me more about XYZ in the book that you're writing that just doesn't make sense? Or maybe it's something that your experience is different than mine and you want to discuss the compare and contrast. I'm not going to be offended. This is a non-judgmental channel. Or maybe like some of my readers will go, Peter, I appreciate what you're doing there, but could you put this on your list of books to write? Because a number of the books I've written from reader input, whether it's somebody commenting on YouTube or Facebook messaging me or commenting on one of the Facebook groups that I participate in. So I always appreciate that opportunity to dig in deeper with you and share my findings with you. My goal as a fellow hospice nurse is to let's lift up everyone, let's help everyone bloom and to grow, and just to be awesome out there. I appreciate each and every one of you. I thank you for your time. Next week, we're going to be looking at the cardiopulmonary impact in pharmacology. That'll be either Monday or Wednesday at the latest. The next episode after that, which will depend on if I do Monday or Wednesday, is going to be looking at a deeper dive of we're in the field without data. How do we interpret all these different things we're seeing and correlate it to the pharmacology of what's going on, and what does that mean for our patients? And then after that, just giving you an idea of what's coming, is there's going to be a chapter on we've walked into a situation, whether it's a home patient, this is more rare in home patients, but I've had it happen to me, or in a facility where it's more common, where we go to do a med rec and look, where did this come from? I didn't anticipate a doctor prescribing medication XYZ or making these changes. And again, the doctor always has the final say, but if we see something that's throwing off the flags, we need to at least do due diligence and advocate for our patient and call the doctor up and say, I'm concerned about this. This may lead to an unsafe situation. Here are my recommendations, and to go through that. And I want to present that from the standpoint of using that CUS framework: concerned, I'm uncomfortable, safety situation, let's stop and think this over. To the other method, DESC, that deals with more complex situations. What does that look like in provider conversations, just to equip you and give you more tools to work with when you're out there in the field. And then I might be wrapping up the book after that. I'm still trying to work through, because I don't believe in adding fluff to the book. So I just want to add what's going to be right for you, along with the appropriate appendices that turn into handouts for that. Uh, I'm also working on Hospice Tools of the Trade. So I'm working on two books, not at the same time. I'm juggling in terms of taking different pieces of information to add into. Here's a book that will be 8.5 by 11 that you can make copies of this page or that page, including brain sheets, handouts, and so on, that you can have as part of your clipboard. Anyway, thank you so much for watching. God bless, and bye.